The idea of this talk is originated from colleagues who doesn't normally ventilate patients. So they've asked me if I can perhaps give them a lecture on ARDS, that being sort of the problem that one has to deal with if you need to ventilate these patients. And I agreed to do that. And I used a lecture which I annually gave to the registrars, and I gave this to the audience. It was in Afrikaans. Subsequent to that, there was a request that I repeat this and do this in English. So this is the reason why I'm repeating this now, and I hope you may find it interesting. So the idea would be is just to talk about the sick lung, which and of course it relates to COVID. And I would like to make a point right at the beginning that the lung injury, which seems to be a big problem in these patients, is not limited to the lung parenchyma itself. It's also significantly involves the lung vasculature, and I'll show some very interesting slides to convince you that this is a big issue that's often missed or mostly missed by colleagues when they deal with these patients. So, and for the rest, it will sort of be a bit of a touching here and there just to remind you of some of the issues. Now, first of all, the question of ARDS, or the adult acute respiratory distress syndrome, that we need to know, this is not a new thing. It's been around and it's been, I think, referred to in 1927 already, where this publication described the lung, which we would today probably call ARDS. I'll just quickly go through this. In 1945, after the bombs in London, there was description of a lung condition which these people termed, or they defined it as oxygen-resistant hemorrhagic pulmonary edema. Now, if you know the pathology, and then I think that is a very clear description of what we would today would call ARDS. Probably at that point in time, they wasn't aware what they were dealing with, not as much as we now know today, that is part of a systemic inflammatory multi-organ disease. They described the lung looking like a liver, which we are familiar with, and it's stiff. And they also referred to, at that point already, to pulmonocardiac failure. And I emphasize the cardiac because I've noted in the 1980s that the patients often died not because of severe hypoxia, which was there, but it was manageable, but often I had a circulatory collapse at the end. So that already alerted me to the fact that it's not only a lung disease, it also involves the pulmonary circulation. This is just a description in the 1950s. They thought it may have been fluid overload, and then in 1967, at the end of the beginning of the Vietnam War, it was described, this condition, that patients will have will suffer trauma and then be admitted after 2-3 days with a progressive lung dysfunction, which often killed the patients. And what they noted at that point already, and I mentioned this just to put this new fake news going around that this is actually a disease of clotting and it's all new and it's unpeer-reviewed data being disseminated. In 1967, Hardaway already said that DIC was usual in the patients with severe shock, and this within the context of the acute lung injury, which they then had to deal with. So this is clearly not new. In fact, it's pretty old, and it's been there all the time, and we see this often in our critically ill patients. This is a very interesting summary, which I read as a registrar. No, it wasn't a registrar. Yeah, as a registrar, summarizing the management of the war wounds after the Vietnam War. But again, they referred to this very problematic condition of a progressive decrease in lung function and young soldiers dying, although they may have had an injury to the femur, for instance. And this is how I met ARDS when I started working in the respiratory unit at Tygerberg. A patient will have a femur fracture, and on day 3, the orthopedic surgeon will ask you to come and have a look at somebody who's got this peculiar condition of a lung being attacked, and which shouldn't have a relationship with the femur fracture. This is exactly what the ARDS was about. In 1967, Ausbach and Petty described the acute respiratory distress syndrome in adults, and they referred to this histology, which is now well known, the hyaline membranes, which we see on the histology in patients with ARDS, and the X-rays, as you are probably all familiar with. And what they first noted is that positive index-pipe pressure was very helpful in relieving the hypoxia. Now, this was the first time, as far as I can determine, that PEEP was actually used in these patients. This was preceded by George Gregory, the pediatrician in Los Angeles, using it in little kids or neonates, which is now different from what we had to deal with. But here it showed that if you could restore the FRC, you can somehow manage the life-threatening hypoxia, which was the hallmark of the disease. This little booklet was written by Blaisdell and Lewis, summarizing this whole, at that point, not well-defined condition of a lung injury after surgery. Now, if I look at the pathology of the ARDS or the acute lung injury, one needs to understand that this is simply part of the systemic inflammatory response syndrome and the well-known multi-organ dysfunction and failure that we see in these patients. What Ausbach and Petty has shown that if they can get the patient to survive with the use of PEEP, they then expose the DIC, the renal failure, and the cardiac failure, and the patient still die, just to confirm the concept that there was a central driver in the form of an inflammatory response, which is then different from just a simple pneumonia, where there's a bacterium, for instance, in the lung causing a localized infection, and you may end up with hypoxia, fast breathing rate, stiff lung, but it's not the same as the acute lung injury or ARDS, where there must be a central driver in the form of an inflammatory response. If you look at the pathologist's view of what we then call ARDS, they call it the diffuse alveolar damage syndrome. They have an acute and an organizing stage. You have some injury, and of course it can be infective or non-infective. It causes epithelial injury, sloughing of the type 1 pneumocytes, denudation of the basement membrane, at the same time endothelial injury and leaky capillaries because of the destruction of your glycocalyx and your tight junctions, and that you end up with an edematous lung with hyaline membranes. So the edema, which now all of a sudden became such a new finding, has always been part and parcel of the early stage of ARDS. It's not new. Then there's a type 2 cell proliferation and inflammation. You end up with organizing stage, either the recover can have fibrosis or the patients may well die. Often if patients recover in a year's time, the majority will have normal lungs because of the remodeling of the lung. I just want to show you some slides of my own. This was taken over many years in patients dying with ARDS in various stages of their disease. This is just the macroscopic view of the liver. It will sink in the water. If you take out the lung, it's heavy. This shows you the severe hemorrhagic edema. An interesting thing is that you can already see that there's some alveoli which there's some resemblance of normality, not normal, while in other areas there's nothing. So one of the interesting things is I thought that an ARDS is this patchy appearance or attack on the alveoli. It's not that every alveolus will be diseased to the same extent. Again, I'm showing you there's an alveolus. There's some air there, but there's debris, the pneumocytes. But this one and this one is filled with protein-rich, fibrin-containing debris, filling up the whole alveolus. And it's not difficult to see how this will act as a shunt and result in a decrease in your arterial oxygenation. But again, the point being that it's a patchy disease, which is interesting when we talk about the management of the ventilator. Now, then there's an inflammatory response, and you end up with hyaline membranes in the lung. There they are. And the next thing is the fibroblasts moving. Those are the cells with a spindle-shaped nuclei. And you end up with a lung with fibrotic areas. The blue is stain used to show the fibrosis. And you can see these alveoli are completely obliterated by fibrosis, and these ones are actually in reasonably good shape. So you end up with a sort of fibrotic lung. So that's the progress of the pathology in these patients. Now, in terms of temporal change in the lung pathology, I found this slide very instructive. If you look at the fraction of an event, one being the maximum of the event, the edema is the 1 to 3 days. This is the issue. And that's why I'm so surprised now all of a sudden to find in the literature, this is a new finding that the patients are, this is actually an edematous lung. Of course it's an edematous lung. That is the first part of the ARDS or acute lung injury progress. It's been demonstrated a long time ago. So you end up with a hemorrhagic edema, then there's the hyaline membranes by about day 4, 5, the inflammation by about a week, and the fibrosis by about 2 weeks. It will appear. Of course, this sort of a nice clean graph rests on the assumption you had a once-off injury and it was taken, you could switch it off, and then the whole disease was allowed to progress on its own. And we know that more often than not, this is not what we deal with. We deal with sepsis mostly, and this is often a continuous process, and you lose this very clear sort of progress of the pathology. But just to make the point that edema of the lungs are always the first thing to occur. Now, as far as the definition is concerned, we can go through this rapidly, but just to make a point, during the Vietnam, there was respiratory distress, usually by day 2.5, 3 days. And what I want to highlight here, they noted in these young soldiers that many of them had CVPs above 20 centimeter water pressure. Now, you may suggest, well, they simply overtransfuse them. It is a possibility, but I would rather suggest they had severe right heart failure because of the severe pulmonary artery hypertension, which is part and parcel of the ARDS. So there was an early warning, at least, that there is something undue happening in the circulation while everybody was concentrating on the lung. These are the parameters that they used: hypoxia, X-ray. The patient is mechanical difficulty, the compliant lung is stiff. They showed increased pulmonary shunt, but remember they used the central venous blood, which is incorrect, but at least there was an attempt to apply a bit of science, which I appreciate, and the patient had a fast breathing rate. The surgeons, Shiles and Carrico and Canizaro, they had the major and minor elements, hypoxemia, stiff lung, X-ray, and then they added these to their definition. Then there was a change in concept. Where previously we thought that, well, look, once you have this, it's a sort of all or none attack on the lungs, and it turned out not to be correct. There was a graded injury, and so instead of talking about ARDS in all of these patients, the term acute lung injury now became part of the nomenclature. And there's then a grading from a mild acute lung injury to then the severe, and the severe one is the one that we will today refer to as proper ARDS. Now, Murray, I think, made a significant contribution in how to define what we're dealing with. He said that it's a three-part definition. The first part is, are you dealing with an acute or chronic stage? Simply because in the initial stages with edema, the treatment will be significantly different from at the end when you deal with a fibrotic lung. So yes, the stage in which the patient is of some importance. Secondly, then you can grade the injury of the lung. I'll come back to this. And then thirdly, they said you have to mention the cause for the lung injury. The reason being, we all know that the outcome, for instance, for a proper aspiration pneumonia is not good. While if you have fat embolism, it can be quite stormy by day 3. Usually it's got a benign course and you're home free. So the cause of the problem does play a role in the eventual outcome of these patients. And so when you discuss a patient with a colleague, try and incorporate these three elements, because at least you'll talk about the same entity. And that's one of the problems that I have with some of the peer-reviewed publications going around, is that they don't mention the stage in which the patient was when certain things happened, and there is a significant difference which must be figured in. Just to show you the 4 elements that Murray used to score the lung injury. Look at the X-ray in quadrants, gave marks for it. Hypoxemia, they used the PaO2 FiO2 ratio, excuse me, and they gave marks for that. And then how much PEEP you require, of course, that becomes a bit of a subjective application of PEEP, but nevertheless, everybody's got the same goal, is trying to improve the oxygenation, and then they would score this, and then the compliance when available, and we calculate this as simply the tidal volume divided by the difference between the plateau and the PEEP pressure. And then there they give the values that they would look at, and they would score those. Now, if you, on average, you take the available ones, and you get the average. If it's more than 2.5, you will call this ARDS. If it's less than 2.5, more than 1, you would refer to acute or mild to moderate acute lung injury. So obviously the outcome to some extent will be determined by the degree of lung injury. So it becomes important when you talk about the prognosis for a particular patient. The next sort of episode in the definition was that the European American consensus, it's ARDS is acute form, a severe form of acute lung injury. So they've now bought into the acute lung injury concept. Acute lung injury is acute bilateral infiltrates. That will make it an ARDS, actually hypoxemia. And very important, you have to be sure that you're not dealing with elevated left atrial pressure, mitral stenosis, cardiac failure, i.e. You're not dealing with simple pulmonary edema, which often becomes confusing because it may be part of your problem, but be careful that this is not the driver of the clinical problem, what you then call acute lung injury, because that's not an inflammatory disease. It may simply be because of congestion. The important differentiation between the acute lung injury and the ARDS is simply the parenchymal injury, and as reflected by the PaO2 FiO2 ratio. I've got that wrong, I see. That should be the FiO2 ratio. Less than 300, but more than, and this is more than less than 200, they would regard this as ARDS. Now, the latest in this saga is the Berlin definition. I think this is what most people will subscribe to. They say, well, it's a lung injury within a week of a clinical insult. There's bilateral opacities, which make it an ARDS and not just acute lung injury. The edema is not explained by cardiac failure or fluid overload, and then you have difficulty with oxygenation, and they then have the mild, moderate, and severe, and they look at their ratios, which you're all familiar with, and on more than 5 PEEP. So this is, I think, the general sort of accepted definition and the stratification of the degree of parenchymal injury. What they actually added, which I thought was very useful and important, is that they were, I think, the first to recognize the role of dead space. There's an increase in dead space. Now, they used the corrected minute ventilation, which they calculated in this way, and it's important when talking about the severity. But the question arises, if you have alveoli filled with debris, why would it act as a dead space lesion? I can follow that it can act as a venous admixture of a shunt or a shunt lesion, but why would it act as a dead space lesion? And I suspect that the dead space lesion that they determined in these patients originated from the vascular occlusion. And I will show you the slides later on. So you have a ventilated alveoli not being properly perfused, which of course is the extreme form of dead space. And they also referred to the decreased compliance, and they added a value less than 40 milliliters per centimeter water. And this is the way the static compliance of course, is calculated. So I think this is the definitive way to actually diagnose that you are dealing with ARDS. Just a word of warning, the PaO to FiO2 ratio is commonly used, but if one critically analyze the factors involved in hypoxia or difficulty in oxygenation, you'll see there are many others, and these are not the only factors. And I've therefore correlated the properly calculated shunt in 102 patients with the PaO to FiO2 ratio at the time when I calculated the shunt. You come up with this sort of nonsense. I mean, there's no correlation whatsoever. And I think it's a big concern. It's ignored by everybody, but this is commonly used, and it does have a place in our discussion and thought processes. But be careful to take poison on this as being a very accurate index of the parenchymal dysfunction, and this is probably a topic on its own for another at another occasion. Now, if one asks yourself, if you stand next to the bed, what is it that I have to resolve? And I can summarize this, that I'm dealing with an acute restrictive disease because of a reduction in the FRC. And if I then look at the result flowing from that, I can understand what's wrong with my patients. I have low VQ units with either venous admixture or shunt, and that will drive the hypoxia. Secondly, you have a low FRC with a stiff lung, and that, of course, will translate into increased work of breathing and the clinical results of that. You also have a decrease in peak flow. The patients can't cough because of a low volume. You know what they like when they come into your unit. They're short of breath and they have this very ineffective cough because of the low lung volume. Then you also have acute pulmonary hypertension, which is driven by other mechanisms. We'll come back to this, but this could lead to circulatory failure, mixed venous desaturation, and that will add to the problems with hypoxia. And unless you recognize this, you will attack the lung with PEEP, and you may in fact make this worse. And then, of course, there's the increased dead space lesion, which together with the hypoxemia and the work of breathing can explain the increased breathing rate, which is one of the hallmarks of in these patients. So as far as management is concerned, some ideas in terms of pathophysiology and just the process itself. And obviously this is not dealing with every topic in detail, but just referring some which I think is probably more important to know about. Now, first of all, the pathophysiology, what we're trying to manage buying time is you ventilate the patient and you need to take care of the fluid balance. And I'll show you some very old slides with regard to the role of excess fluid in these patients. And then there's, in terms of the treating the process, anti-inflammatory drugs, ketoconazole, heparin, antithrombin, 3 actually, protein C, activated protein C, steroids, and I'll just briefly refer to some of these. Now, how do I restore the FRC? Well, the first thing is to recruit the alveolus. Remember that the time constant for inspiration is the elastance times the resistance, and the elastance is high in these lungs. So simply applying PEEP will eventually give you a reasonable FRC, but it'll take an inordinate amount of time. You can get there much more quickly by simply recruiting 30 centimeter water pressure for 30 seconds on the dial, and then make sure that the PEEP that you want to apply is already dialed in. So when you switch over to your ventilator, you immediately get the effect of, or you can maintain the PEEP there, or the recruited alveoli, which you've won back with your recruitment maneuver. Then, of course, you have to maintain your FRC with PEEP. And PEEP is, to me, like a drug. You need a dose, and you need to be able to titrate your dose, and I'll briefly refer to that a bit later on in this talk. Now, as far as the parenchymal pathology is concerned, it's important that one understand that there are various ways to look at it. You can either look at it as a global but patchy parenchymal process, as I've shown you in my slides, or you can think of it as a regional parenchymal disease, and this is the baby lung concept, or it can be a combination of both. I frankly think it's a combination of both, and it impacts on how we treat these patients. This is just a few slides demonstrating the concept of the baby lung, where you have a dense congestion of the dependent parts of the lung, so that for this particular size patient, the aerated lung is insufficient. It's too small. That's where the concept of a baby lung comes from, the same as you can see over here. This is just another example showing you in the dependent part the atelectatic lung, and if you apply PEEP at the base, you can overcome or recruit at least this alveolus. So this is the concept of the baby lung. Now, on a micro level, this is the patchy injury, as I've shown you. Now, you can imagine if I now misapply my ventilator, that I distend this alveolus where I suspect, I don't have proof of that, but I suspect the compliance of this alveolus and this one is better than this one, then the distension will primarily occur in this alveolus, and you will injure the alveolus. This is where the volume trauma comes from. If you look at it from the point of the baby lung, then the compliance in this area of the lung is clearly better than the compliance of these non-aerated areas. So if I apply a ventilator, distension will occur in this area, and you may over-distend this and you may injure this lung. And this is the concept of volume trauma, or and it dictates how we should ventilate these patients. Now, what we're trying to do with PEEP is simply to take the patient from this part of the lung compliance curve where it's non-compliant. You need a big pressure differential to move a small volume, as opposed to where we function normally on the steep part of the curve, where you can move a bigger volume with a smaller pressure. So you try and apply PEEP and restore the lung volume to move generally, on average, the patient to this point on the curve. Of course, if you overdo this, you end up over here, and the compliance here is no better than the compliance there. And we'll come back to this. This is, if you over PEEP, it has all sorts of effects which is best to be avoided. So you need to be able to titrate your PEEP to some reasonable end point. This is just to show you what happens if you PEEP a normal patient and an ARDS patient. This is volume, and this is transpulmonary pressure, various levels of PEEP. You can see there's the FRC when they start at 0 PEEP, and then that one there, I'm sorry, the pink one, there is 10 PEEP, and there is 20 PEEP. So you can see the FRC going up as you apply your PEEP. In the ARDS patient, there's your 0 PEEP, it's very low. If you apply some PEEP, you improve your FRC. If you apply more PEEP, you get into a value which is much better, and hopefully you can oxygenate your patient. So the important thing to understand is that the only thing that PEEP does is to restore the FRC, and all the rest follows logically. The reduction in the pulmonary vascular resistance, the oxygenation should improve, not always as you want it to, but it should in principle. Important to understand that PEEP does not get rid of the water in the lung. It simply distributes the water into the corners of the alveoli, which are not round objects. They are hexagonal, so they've got 6 corners, and it's the water is then compressed into these corners, or the fluid is mainly compressed into the corners, which then allow for improved oxygenation. Interesting thing is that Gattinoni has looked at the aerated areas in the baby lung, and they show that the compliance in those areas is actually not bad. So it leaves one with the impression that the aerated lung has actually got a good compliance. So you can imagine if you apply excessive volume with your ventilator, that area will distend, happily distend, because it's reasonably compliant, and you will injure the lung. That's where the volume trauma concept comes from. Now, obviously, we're trying to oxygenate the patients, and one need to remind yourself of the causes for hypoxia. There are 5 of them: decreased FiO2, insufficient alveolar ventilation, venous admixture, shunt, and then the last one is a shunt plus a decrease in your mixed venous saturation. Now, obviously, this is not an issue when we deal with the patients. We deliberately adjust the alveolar ventilation, trying to prevent volume trauma, so we may end up with hypercarbia, which we can live with. These are the main ones that we need to consider when we deal with the hypoxia, and they all these two relate to your FRC, this relate to your circulation, and especially your right ventricle, and this is often missed. And of course, you're going to apply your mind to these options in the spontaneous breathing patient, to the one on the ventilator, even on going on to ECMO. One need to just think this through. Do I understand what is the reason why a particular patient has difficulty in oxygenating? And am I applying a correct remedy if I think I understand the reason for the hypoxia? It's useful to remember the little West cartoon, which tells us that your arterial oxygenation, which is over here, is simply the combined, or the product, or the combination of the blood that actually sees an alveolus, your capillary oxygen, and this will be 100% saturated, because even in the very diseased alveolus, the hemoglobin will be saturated, the PO2 will equate with alveolar PO2, and that then mixes with blood, which comes through the shunt in the lungs. And the shunt has got 2 components. It's a volume, size, if you will, and a quality, because the mixed venous, if the mixed venous is desaturated, you can imagine that this will detract from this ideal capillary, and you'll end up with your arterial oxygenation. And now, this being sort of a constant, you can conceptually understand what's going on here becomes the major determinant of what is going to happen to your arterial oxygenation. And when you deal with your patient and thinking about PEEP and application of PEEP and manipulating shunts and mixed venous, this is a very useful little drawing, and it comes from West. Now, just to give an idea of the injury to a lung and its effect on the oxygenation, the non-isoplates are very useful in this regard. It relates the inspired oxygen concentration with your arterial PO2 for various shunts here on the right. Now, if you have the ideal lung, which of course doesn't exist, there will be a linear relationship between the inspired oxygen and the arterial PO2. But as the shunt increases, it becomes more, the curve flattened, and you can see by 20%, you're sort of at about 100 millimeters mercury PO2, which is fine. But once you get to 25, you are way down and getting into the area where it's a concern. And this is the, and I'm referring to 60% oxygen for the simple reason we know that in normal lungs, that using more than 60% oxygen for a prolonged period of time can end up injuring the lung. So it's not necessarily the same in the injured lung, but it's just to make the point. So conceptually, if you have a patient with an acute lung injury in a shunt in excess of 20%, it is unlikely that they will get by without some form of support. So this is where the 20% threshold comes from. I want to just briefly warn about something, and that's the use of CPAP, which at times I've seen is being incorrectly used, and you end up with spontaneous breathing with PEEP. Now, what's the difference? I've tried to draw it here. It's pretty basic, but this is your pleural pressure. This is negative. This is positive. This is the patient with spontaneous breathing getting PEEP. Is inspiring negative pressure, and then he's being is getting his PEEP over here. While the CPAP is swinging on the positive side, as the name actually suggests it should, continuous positive airway pressure as these yellow lines. Now, the work of breathing being the product of the change in pressure and the change in volume is much more in spontaneous breathing with PEEP, and often patients will fail especially the sick lung, they will not tolerate this. So you need to be sure that when you're applying what you think is CPAP, that you are actually applying CPAP. And the simple way is to look at the dial on the ventilator and make sure that you are swinging on the positive side of 0 in both inspiration and expiration, and do not go below 0, because then you are doing this, which I think is asking for trouble. Now, the protective lung ventilation became the standard after the publication of Amato in 1998, showing an improved outcome in patients that were subjected to protective ventilation versus conventional ventilation. And this then became the standard recommendation by the various authorities that we need to apply protective ventilation. And it can be summarized, and this has recently been reviewed again, tidal volume approximately 6 milliliters per kilo, PEEP is required, plateau less than 30, and a driving pressure less than 15. This was Amato and Slutsky discussing the concept of driving pressure as being the difference between your plateau and your PEEP. I also think one needs to think about the inspiratory time, given that the time constant is prolonged because of the elasticity of the lung. It will be fairly counterproductive to use a short inspiratory time. I, for instance, will not go to lower than 2 seconds, and this is usually my starting point in these patients. Obviously, if you go faster on your inspiratory or shorter inspiratory time, you have a faster flow, you end up with an elevated peak pressure. Often colleagues will look at the peak pressure and think that is the one that they have to make the decision on. That is not so. You need to look at your plateau pressure. Now, if we use small tidal volumes, you're invariably going to end up with elevated carbon dioxide, because we know of the inverse relationship between the minute ventilation and the PaCO2. Now, it was then, Gatnoni and colleagues then used an extracorporeal CO2 removal, low flow extracorporeal circulation, trying to remove the carbon dioxide, and they showed encouraging results, but eventually it was shown not to make any difference. And I think that the definitive study was Morris from Salt Lake City in '94 already. There's no difference in the outcome, and ECMO does come with a very labor-intensive exercise. But we were saved by Hickling with the concept of permissive hypercapnia. The idea was that, well, if the carbon dioxide is elevated, does it really matter? And he showed an improved outcome if they would allow this. Now, obviously, it's not the carbon dioxide that improved the outcome. It was the fact that they used a low tidal volume. They had a protective strategy. This just showing the pink blocks how they always had an improved outcome in their patients if they applied a protective strategy. So the use of lower than previously used lung volumes, I trained on 10 milliliters per kilo, which very quickly then came down to the 6 milliliters per kilo. And then the resultant hypercarbia is not a big deal. I wouldn't allow the pH to go below 7.30 for the simple reason we know there's a tight correlation between intra and extracellular pH, and neutral intracellular pH is of vital importance for normal function, including cardiac function, and I'm especially interested in the right ventricular function in this scenario. Now, iBox is a method which I'm not sure why it's not developed further, where you try and use a mechanism to oxygenate your inferior vena cava blood, because you can do that. You can push the oxygenated venous blood through the shunt and you can make the lung rest. There's some problems with this, but I think the issue here is actually materials. You need a very strong material which can take high partial pressure of oxygen which you want to put into this device, but it should allow for the diffusion of the oxygen. Of course, you can imagine it's got to be very strong, because if it should break, the patient will be dead because of a massive embolus. So it's probably an issue of materials, and this is something which I think should be considered rather than the chase after ECMO, which is very popular at the moment. Now, what about ECMO? Well, it's important to understand that ECMO is debatable, but in the H1N1, it did improve outcomes. So I will not discount ECMO, although the data at the moment, generally speaking, is not in support of the use in acute lung injury. But we are now dealing with COVID, which is another virus, and one must keep an open mind whether it may also, like in the H1N1, perhaps give you as good results as in the H1N1 patients. If one look at the data, the CESAR trial was the one that sort of was used to promote ECMO. I think it was subject to so many criticism, one can basically ignore that. There was, just go back, the indications which Coombs proposed in 2017, he said that you should consider your ECMO if your risk of dying is 50%. And this will be in a ratio of less than 150 on 90% oxygen, a Murray 2-3 score, and it is indicated when you've got a risk of dying 80%. And obviously, I mean, this is going for broke. This very severe parenchymal pathology and a high Murray score, plus or minus hypercapnia, or difficulty with your inflation pressure. I find this a useful way of thinking about it, when to consider and when perhaps it is indicated. Otherwise, you're going to lose the patient in any event. This is also just another approach to the Australian recommendations. Again, very severe lung disease and hypercarbia. Now, the last word in general in terms of ECMO at the moment is the EOLA trial. And there is no difference. And this was 2018. So this is quite recent, confirming that in general, ECMO does not end up giving you a better survival. But as I've said, dealing with a virus and with the history of the H1N1, I think one should keep an open mind. Oscillation in adults does not really work. I know in the small babies it is perhaps of some value. But in adults, it has not been shown to be of real value. What about proning? Now, proning improves oxygenation in certain patients. Your responding patients, some does not respond. But obviously, the proning becomes a factor of time. If you have a fibrotic lung, I'll be surprised if proning will be of any value. If you have an edematous lung, I would expect proning to be of value. That's why often patients who are less severely ill can self-prone with the COVID. They said it does help. So yes, early on, proning may well be of value, but don't confuse that with an improved outcome. It may well assist you with oxygenating your patients. Gatnoni has shown that there was a general no improved outcome. What is a concern is the complications. I can tell you that if you prone a patient with severe ARDS and the tube comes out, they will be dead before you got them back on the back. The reason being that they've got such small FRC, the lungs are so stiff that they become very, very, they develop very deep hypoxia very rapidly, and often you get into difficulty before you can actually gain control of the situation. So that is rather scary, and one has to take cognizance of the risks involved in proning. The data that's out now, Baker also said, well, no survival benefit. Guerin said that they had an improved outcome in a certain group of patients. So again, I think one must, the oxygenation issue early on, I think is a very helpful concept, but be careful to equate this with improved outcome. Now, another treatment which I thought was actually very appropriate, and it was done before, but it came to my attention in February of this year in the Journal of Cardiothoracic and Vascular Anesthesia, and I had so it was published before the corona, before COVID actually came out. But what these authors did is they used patients with severe ARDS, and there was quite a bad group, 90 patients. They either nebulized them streptokinase or nebulized them heparin, or no nebulization, and then they looked at what happened to the patients. Now, what is the basis for this concept? Well, the basis is clear. This is a protein-rich exudate. If you can get rid of this, then I can, in my mind's eye, see that I can improve the oxygenation and perhaps even the compliance of the lung. And this is what they could show. And I apologize, the slides didn't copy all that well, but look at their ratio. They had an immediate improvement in their streptokinase, and it continued improving for the duration of their study. It's quite dramatic, in fact. While the standard care, there was no improvement. If you look at their plateau pressure, it came down progressively in the streptokinase group, and the calculated compliance was then significantly better in the group who received the streptokinase as compared to the heparin or the control group. What was impressive, and one just need to remember that the numbers are still small. It was 30 patients to a group. The streptokinase had a 35% mortality, the heparin group a 70%, and the standard care 90% mortality. Now, if this can be shown to be true in more studies or in bigger studies, this is, I think, a very useful adjunct in treating something which is there all the time and which will buy you time to for the patient to recover from the injury. So I thought that this was a very useful adjunct and concept, which I certainly is going to apply. And I'll show you some new data which I received last night from a journal prior to the publication. Now, muscle relaxation, well, when that becomes an optional thing, as Arthur Slutsky said, antipyretic agents for ARDS, yes, no, and sometimes. So it's an individual thing. It may serve a purpose, but as a general starting treatment, it's not indicated. I think you must have an indication to use this, and make sure you have proper sedation at the time when you apply muscle relaxation. Now, what is the baby lung and the barrow or volume trauma concept? What is that? The term volume trauma was coined by Warren Zapol in 1992. And what is important to understand is that it's not the pressure. It's the distension of the alveolus. The reason, if you apply a negative pressure ventilator, QRS, you can also end up with alveolar distension and acute lung injury, as you can do with a positive pressure ventilator. So it's not the pressure per se, it's the resultant alveolar distension. For instance, if you have high airway pressure in a patient with abdominal strapping, thoracic strapping, high airway resistance, abdominal distension, the alveoli are partially protected, and you don't necessarily get the acute injury as indicated here. So just to make the point, of course, the pressure is in our case, is the driver, but the question is the alveolar distension. I'll skip that. Now, there's various stages. It starts as interstitial emphysema and can end up as dramatic presentations like a pneumothorax or a pneumopericardium. Now, the whole concept is interesting because why would an alveolus be injured? Because it is supported by its neighbor. It's called interdependence, like putting balloons in a box and closing the box. They shouldn't break because they are supporting each other. But there are areas in the lungs where there are no support, and it's the alveoli lying adjacent to the bronchovascular sheath. And this is where the injury occurs. If you distend these ones, they tear into the bronchovascular sheath, and from there it will then move to the mediastinum first, and you'll see this as interstitial emphysema, a pneumothorax into the pericardium. We had a tamponade recently, and it may even have air under the diaphragm, which may be a diagnostic dilemma, and you might be thinking of a gut perforation. So this is the process. It's not if the alveolus break into the pleura. It doesn't happen. It's via this mechanism, and this has been published in 1942 by Macklem and Macklem. Now, interesting thing is, if you look at the leakiness of the lung, the KFC is an index of leakiness of the lung, and you take the lung out of the chest. Even if you apply a low pressure to the lung, it starts leaking. Right, there was the baseline value, and there it starts leaking. And at high pressure, it leaks just as much. So it even occurs at low pressures. The reason being, you don't have the lung inside the chest, where the chest wall then acts as a counter pressure to the distension of the alveolus. If you leave the lung inside the chest and you put a body cast on, plaster of Paris body cast, see what happens. Even at high pressures, there is no increase in the leakiness. So just to confirm the concept, it's not the pressure per se, it's the transalveolar pressure and the distension that goes with that, which causes the alveolar injury. Interesting is to see that this slide actually, again, there's your index of leakiness, there's your airway pressure, and interesting thing is, look where it sort of seems to be changing at 30 centimeter water pressure. It seems like there's now a continuous increase in the leakiness. Now, if you think back of our guidelines, which says keep your plateau below 30, then it seems that it has a basis in experimental physiology already in 1984. At 30, it seems that things happen which will cause us, or what could lead to further lung injury. So interesting that there's this correlation between what we have concluded in our clinical practice and what has been shown in well-controlled experiments. Now, what happens is the following, that you have this is from John West, there's a stretched pore from the capillary, there's then blood leaking into the interstitium, and then if there's an opening up of a tearing of the alveolus, this protein-rich fluid with then in the SIRS patients with activated neutrophils will now leak into the alveolus, and that alveolus will become inflamed, and it will become part of the ARDS. So you can now see that we can start with a lung who's got little areas where the alveoli are reasonably in reasonably good shape, but they may get injured if we don't get it right, and this is the mechanism. And this is just to show micrographs from John West showing the tear in the endothelium. There's a tear in the alveolus. You can see there the tears in the alveoli, and you can now imagine the protein-rich fluid and the activated neutrophils leaking into this alveolus and causing severe damage, or making it also a diseased alveolus. Or prior to this event, it may have been in an acceptable shape. So what you have is the opening up of the tight junctions and injury, and then you have protein-rich material and activated granulocytes, which are essential, leaking into the alveolus and setting this alveolus up for inflammation. Now, how much PEEP should I use in my patients? Well, there are different approaches. Either you can go for a minimum shunt, which means you're going to optimize or maximize your PaO2. Or you can go for delivery of oxygen. Remember, if you apply PEEP, you may limit your cardiac output, not necessarily so, but it could, so that although you may gain on your oxygenation, you may lose on your delivery of oxygen to the body. So it's a philosophical approach. Which one would you like to support? The one is called best PEEP, which is that you target the PO2, and the optimal PEEP, which you target the DaO2. I use, for one thing, the compliance of the lung to try and optimize, or to try and titrate the PEEP. I start with a lung which conceptually lies over here on my pressure volume curve. It's a stiff lung. You need a large pressure differential to move a small volume. I apply PEEP, and I hopefully move the average up to this position where I can now have a better compliance, and of course, hopefully the oxidation will improve. And you don't want to end up with hyperinflation because it will become stiff again. And as I've said, I calculate the P plus tidal volume plateau minus divided by plateau minus P. I know the machines give you this is a static calculation. The machines will give you a dynamic calculation. I find it often very uncertain, and I elect rather to stick to my static calculation. So I go for maximum compliance, and remember to use in your equation, use your peak, your plateau pressure, and not the peak pressure, because at peak you have the resistance to airflow and the compliance playing a role in generating a particular pressure, while at the plateau phase there's either no flow or less flow, so it's more a reflection of the compliance of the lung. And this is the equation that I use. And remember that if you take the lung out of the chest, this is normal value. Inside the chest, this is the 100. And below then 50, it's clearly abnormal. Below 25, it's severely stiff. Of course, there's wide variation for the simple reason that this is a static and not a very necessarily very detailed, accurate calculation. But if you apply this on a particular patient, you can track the change. The other way that I titrate my PEEP with is I look at my expired carbon dioxide, or I do a Boer calculation. Remember, in Boer, you need to have your average expired carbon dioxide, and the way I get this is with a Douglas bag, small Douglas bag, collecting expired volumes and then putting it through the Kaplan graph, giving me an average value, so I can calculate Boer. Very interesting exercise, but you can simply look at the difference between your arterial and expired carbon dioxide. If it's more than 2 kilopascals, you can rest assured you have a significant increase in your dead space. But if you track your expired as you titrate your PEEP, once this starts decreasing, you are increasing the dead space, you're going the wrong way. So it's important to decreasing, you're going the wrong way. And of course, your arterial PO2 will increase then because you're creating the dead space. You can imagine if I overinflate the alveoli, I don't have effective perfusion, and therefore the carbon dioxide cannot be exhaled, and I end up with an elevated arterial carbon dioxide or slight elevation and a decrease in my Kaplan graph reading. The other way of titrating PEEP is looking at your lower inflection point. This is pressure against volume. If you think about the child's balloon, if you blow up the balloon, initially you apply a huge amount of pressure and then the balloon gives. Just telling you that the balloon was collapsed, the surface tension was very high because of the intermolecular distances, which are small. And then once you've overcome the intermolecular attraction, you have distension, and now you have distension of the balloon. Same with the alveolus. If you see this pattern where there's a clear inflection point, conceptually it conveys a message that on average your volume is small and you have to overcome the surface tension to inflate the alveolus. What you want to see is you want to lose this. You want to see from the word go that there's immediately an increase in the volume as you apply the pressure. So this is the open lung concept. We'd rather have an open lung moving a small bit so that the stress and strain is less. If you can see, you can compare that with the too little PEEP and large volumes, tidal volumes, where you have a lung collapsing to low volume and then being inflated to a high volume. The stress and strain add to the alveolar injury. So one try and avoid seeing an inflection point on your pressure volume curve. It's often quite useful, but at times it's not very helpful to actually see how much PEEP you can use. Now let's move on to the fluid balance. This being such a topical thing recently, there's no doubt, it's been known since the 1990s, that if you have a negative fluid balance, the outcome in your you have an improved outcome in patients with diseased lungs. This is also Humphrey in 1990 already, where they had a low patient with a lower capillary wedge pressure, so less fluid exudation via your Starling mechanism or your Starling equation will tell you how the fluid will move across the membranes, then you have an improved outcome in your ARDS patient. So over transfusion with fluid in the ARDS patient has long been known to be detrimental. It is not new. I know one often gets caught between a patient who has an inflammatory storm with a low perfusion pressure, which is often very detrimental. I'll show you why. And you need to adjust the intravascular volume to the new capacity or the vascular capacity, and one needs to often give some fluid, but be careful and try and use alternative methods. Rather readjust the capacity of the vasculature with your vasopressors or your methylene blue rather than just to give inordinate amount of fluid. And in addition, I'll show you later on that fluid loading fails the right ventricle in the scenario where it's opposed by an acute elevation in the pulmonary artery pressure. What about steroids? Well, it's come a long way and it's still not exactly decided. This is John Luce. Maduri is a proponent of steroids, and also perhaps in the later stage, in the fibrotic stage, which is not what we're talking about. There's conflicting evidence. There's no support in 2007. There's Steinbeck says, well, there's no improvement in survival if you use steroids. As I said, Maduri and Murrock, they support the use of steroids. But Peter, in 2008, it says that the use of steroids in ARDS is not been firmly established. Now, I think one's got to be careful to discount this. Ben says steroids is part of the treatment for refractory hypoxia in ARDS. Point being that if you have really pushed into a corner, obviously one will try this. Same thing, if you end up with somebody who's hypotensive because of the inflammatory storm, what I do is I'll give them a solid dose of Solicortef, and if they respond to that, in my mind's eye, define them at least as being suprarenal incompetent patients, and I will then continue and try and just salvage my hypotension by using steroids. But try and have a definitive reason for using it and not use it as a matter of routine, which I don't think there is support for. More so, given that you're dealing with a viral infection currently, and the data at the moment does not support the use of steroids as a general treatment, but perhaps as a specific treatment to try and salvage a particular problem. If you look at the suggestions by Anani in 2017, they say, well, we suggest the use of corticosteroids in patients with early moderate severe respiratory distress syndrome. They give their values within 14 days of onset. So early in severe or moderate ill patients, they think there may well be a place for using it in general, but as I've said, with a viral infection, one needs to be careful. Excuse me. Now, what about this clotting or the new emphasis on clotting? Let me just make a point. It is not new. In 1976 already, Hardaway said, well, look, when you deal with these patients, DIC, intravascular coagulation pathology, is simply it's a common occurrence. So it's been there for a long time. Let me remind you briefly of what happens in inflammation, either bacteria, viruses, fungi, parasites, or endotoxins. What you have is your mediators, TNF-alpha and interleukin-1 especially. What it does is then via the monocytes and the endothelium gives you an expression of activation of the tissue factor 7, and you have thrombin production, and that leads then to a fibrin clot. This is a very superficial summary of this. But in addition, there's also an activation of the plasminogen activator inhibitor. That means that the formation of the clot it will not be digested by the plasma. So because of this action. Also, there's an expression of the thrombin activator or thrombin lysis inhibitor, which again will then leave the clot which is formed to remain in place. If you add to that the fact that the thrombin and the endothelium injury and with the interaction with thrombomodulin and its role in protein action of protein C, which should dampen down the clotting profile, that is also defective. So it's not new, it's not strange that somebody who has got severe inflammation or the inflammatory storm, like has been described with the SARS patients, that they will end up with degrees of diffuse intravascular clotting pathologies. And I'll show you later on some of the results which I could get. And it seems that it's not severe in the publications, but also there's some peculiar things in that. But again, as I've mentioned earlier, because one don't know what they're talking about. For instance, were the patients on, for instance, deep vein on heparins for to prevent of deep vein thrombosis, which we know will limit this notion or the tendency towards clotting activation. One can't get that from the publication, so one don't know exactly what you're dealing with. But without any doubt, it's a well-described entity, well-publicized, and been dealt with already in the 90s by authors. This is just a very useful summary by Bernard where they discuss the activated protein C. Now, inflammation and clotting goes hand in hand. I mean, it's the one leads to the other. That's been very, very well established. So it is not new. Secondly, that clotting by itself can activate inflammation. So this whole process feeds on itself, and it becomes part of your clinical problem. And then, of course, sepsis and inflammation has got a definitive effect on the endothelium. Well published, very interesting data, I think. And obviously, if you have endothelitis plus a tendency to clot, you can imagine that the clotting process will be accelerated in these patients. And it's not a surprise, or it's not new. Given this question of inflammatory drivers, aspirin was tried in ARDS. It didn't make a difference, but I will show you in the data that I have from the COVID patients that they have normal platelet numbers. And I just wonder if that is so, and you have activated platelets and activated endothelium, whether, in fact, in these patients there may not be a place for some way of partially paralyzing platelets. So aspirin may well turn out to be of some value. Obviously, that needs some careful thinking, but it's just a thought that I had on the use of aspirin. Now, heparin is, in my book, the way that you used to treat DIC. Henny Latoy did his PhD in our department in 1991 already, where we looked at thrombin-induced DIC, and just to make the point, if you're completely heparinized, you cannot get DIC. It's not possible to do so. So now you just have to adjust your dose of your heparin so that you don't end up with a totally heparinized patient, which is not what you want. But at the same time, you need to dampen down this accelerated clotting mechanism. And I, for one, will do my clotting profile and try and define and see whether the dose that I'm giving is in fact keeping this under control. And what I use is a milligram per kilo heparin as a bolus, followed by 300 to 500 units of unfractionated heparin. I don't use Clexane because once it's in, you can't quantify it, you can't reverse it. I use an infusion of heparin and then I will check to see whether I have actually slowed down the clotting process. Remember one thing, that once you use your heparins, you consume your antithrombin 3. You need to top that up, and for that I give the patient a unit of fresh frozen plasma every second day, and it makes an immediate difference in your ACT or APTT. So that's just the way that I use it. I know it's controversial, but without fail, it has managed to slow down the DIC process in my patients. In fact, one of the publications on the COVID clearly states that the patients on Clexane in that case did not develop DIC. So just to make the point. Now, that just to again remind you of streptokinase and the unfractionated heparin. Again, it's been shown that as nebulizations, which I've shown you before, which I think was a very interesting study with promise. The point here is that it's been shown that the streptokinase and the heparin that you nebulize slowly diffuses into the microvasculature, and that's exactly where you want it. So you can, in your mind's eye, cause clot lysis, and then with the heparin being there at the injured areas, prevent new clots from forming. And of course, there's no proof of this conceptual thinking, but I wonder if that's not what is happening, and that would of course be, if one can show that to be correct, it would be extremely useful for both the lung and for the right heart. And I'll show you why. Interesting thing is that ketoconazole prevent respiratory failure in critically ill surgical patients, but the emphasis, and just to show you the figures, single dose ARDS in the ketoconazole group was 15%, there's 64% in the placebo group. The mortality was also much less. Point being, you have to use it prior to the insult. So you have to have a big bin of ketoconazole at your hospital's entrance. Everybody comes in with trauma or whatever should first get a dose of ketoconazole, because it's been shown that once they have a lung disease, it doesn't serve any purpose. So they think it works via the platelet factor, one of the platelet factors, and it may be a useful and fairly innocuous way, perhaps, of preventing or limiting the extent of the ARDS. Now, the Fan, Brodsky, and Slutsky in 2018 said, well, look, when we deal with ARDS, the pharmacological treatments are, there are proponents and there are people as opposed to certain things. So there's lots of controversy and nothing is very clear cut. So that is so, and one has got to individualize and use your experience. But one thing is certainly clear, that the lung protective surgery, ventilation is mandatory. And they suggest proning, yes. Oscillation, no. PEEP, high. Recruitment, yes. ECMO, and they say, well, look, you need some additional information, but I think one's got to keep an open mind, whether it may or may not be of value. Now, let's just leave the lung tissue per se and move on to the lung vasculature. I want to make a very firm point that ARDS is very much a disease of the lung itself, but also of the lung vasculature, and it's got, I think, profound implications on how we manage patients. And this is often missed for the simple reason that most people do not use pulmonary artery catheters, which I do, and they do not look at mixed venous saturation, which I do. And I'm not saying that by doing so, I will improve the outcome of my patients. It's extremely unlikely that a single entity will improve outcome, because if you look at the because of it's a complicated disease with many different aspects that you need to try and manage, and it's unlikely that a single entity will salvage the patient. But on that argument, why use a ventilator? Because it's been shown that in China that once people have COVID infection and they end up on a ventilator, they die as much as patients with ARDS will die. So why ventilate them if you can't improve the outcome? To make the point, you're not going, you do what you can do, you collect the data that you should get to try and make an informed scientific decision rather than to go by the seat of your pants, which I'm afraid is not good enough at this level of medicine. Now, the acute pulmonary artery hypertension has been reported by Zapol in 1977, just showing you there's the PAP pressure in the ARDS patients. And the more ill the lung, or severely injured the lung as gauged by the shunt, the higher the pulmonary artery pressure would be. In fact, they were so sure about this that they said, look, if you don't have pulmonary arterial hypertension, you don't have ARDS, if that's what you were thinking. This is just to give you some values, a prospective study on admission, and this is important. I'll show you my own slides, that once you admit the patient, the problem is already there. So unfortunately, we are getting in at the late stage of this problem, unfortunately. The PAV pressure mean of 35, which is severely elevated, and 92% had acute pulmonary artery hypertension. Now, Zapel picked this up because at post-mortem they saw subpleural infarctions in the lung, and he was wondering why this happened, because the patient did not have deep vein thrombosis. And they did then they did antemortem angiograms, and this is what they could see. Look at the filling defects in the pulmonary artery. That one is totally occluded. That one is occluded. There's occlusion. There's occlusion. So clearly, the vasculature was severely compromised in the patient with ARDS. And given the whole process of inflammation, endothelitis, accelerated clotting, it is not strange that this would happen. It is strange that it would happen in the lung and not in the rest of the body, but the lung seems to be a target. This is one of my own patients showing you a thrombus in a middle-sized arteriole, as shown by Zapel. Now, what he then did is he took the lungs of the patients who died, perfused them with latex, and then put the preparation in acid and dissolve the lung tissue, and then you can actually see the lung vasculature. This is a normal lung. Very interesting exercise. I've done it myself, but messy, but very instructive, I must say. This is ARDS. You can see the occlusions and of the arteries. Many occlusions of arteries. So it's clearly the vasculature is significantly attacked in the process of ARDS. This is a 1 week ARDS, 2 weeks, 3 weeks, and 4 weeks. There is no microvasculature in this lung. This patient will be severely hypoxic and severely hypocarbic and will need a new lung. This is as simple as that. So clearly a significant problem in the pulmonary vasculature in terms of the occlusion. So the point being that the pulmonary arterial hypertension then seems to be mostly a mechanical obstruction rather than a disease of pulmonary artery spasm, or a difference in the or change in the pulmonary vascular muscular tone. I think it's mostly a mechanical problem with clots, as shown by Zapel. We then studied this in pigs. Peter Fourie, for his PhD. Peter is an engineer and also a specialist. Doctor, pediatrician. We use small microbeads to create acute pulmonary artery hypertension. There's the microbeads, and the interesting thing is it causes severe inflammation of the endothelium as well. And then we characterize the right ventricular function with pressure of diameter loops, so we can look at contractile function and its diastolic mechanics. And we quantified the afterload with reference to the elastic properties of the pulmonary artery, which is, in a summarized version, is the two resistances, the proximal resistance and your peripheral resistance divided by your capacitor. He did this in very intricate engineering calculations, but this is the summarized way of calculating this. And we then looked at what happened to the circulation as we created the acute pulmonary artery hypertension. And this is what happened. This is where we started, and then the PAP, that was your average PAP of 13.7, maybe 14 millimeters mercury. So we increase the pulmonary artery pressure as going up here. The first thing that happens is that the right ventricular end diastolic pressure and volume increased. So the heart sort of attempted to use a starting mechanism to overcome the increase in the afterload. Then once you get to about 300% increase, there's a decrease in your cardiac output and an increase in your AV extraction for oxygen, meaning that the circulation is now incompetent. It's not supplying sufficient oxygen to the tissues to maintain a normal AV extraction of oxygen. Now, the 300% level for this is about 40 millimeters mercury average PA pressure. That's exactly the value which Weber and Janicki in their very sophisticated work shown that the right ventricle will fail if it's acutely loaded. In addition, what happens is septal shift, which I think is a very difficult thing to manage. Normally, this is the configuration of the left ventricle to the right ventricle. What happens in acute severe pulmonary artery pressure elevation is that the septum shifts towards the left side, reducing the volume of the left ventricle. But at the same time, you end up with an elevated wedge pressure, and it may be very difficult to decide what you're dealing with. And what I do is I use an echo combined with a wedge pressure to try and understand what is happening here if I then treat or manage to see which way this is going. This is very difficult to manage, I'm afraid, because we don't have much of a handle on the pulmonary artery pressure. Zapol used thrombolysis on systemic thrombolysis, but he ended up with a hemorrhagic lung. So this is an option which one must be very careful. And his thrombolysis was an attempt to relieve the pulmonary artery obstructions and to take the pressure off the right ventricle. But a very difficult scenario once you have septal shift to manage. Now, you may ask me, but why is it important? I think it's of crucial importance in terms of especially the oxygenation of the patient. What I've tried to do here is to show you this data from my own patients, a large number of patients, put them through the data through a computer program, looking at the arterial oxygen content, or the PaO2 for that matter, against a particular shunt for a particular mixed venous saturation here between 20 and 70%. Now, if you have a perfect lung, which doesn't exist, zero shunt, it doesn't matter if the mixed venous saturation is low, for the reason being that the lung is extremely effective in oxygenating the blood, provided there is no shunt present. But as the lung is injured as an ARDS and the shunt fraction increases, you can see that the difference in the PaO2 that you will be able to achieve for a particular mixed venous becomes large and a problem. Now, if we now have a patient with ARDS with lung parenchymal disease, is already got difficulty oxygenating, the right ventricle is overloaded because of the acute pulmonary hypertension, and the circulation becomes incompetent. Then the mixed venous saturation becomes a crucial role player in determining the arterial oxygenation. Now, again, I'm back to getting the data. You need a pulmonary artery catheter, and I think it's important at this level that one get that sort of data to manage the patient. You can try and use the central venous saturation, but remember, mixed venous will always be less than the central venous. So if you can't achieve at least a 70% plus on your central venous saturation, you must accept that your circulation is incompetent, and you have to find a reason why, and often it will be the right ventricle. Now, I can define right ventricular failure very nicely by understanding this graph. It plots the afterload, the elastic arterial elastance of the pulmonary artery, against the stroke work, which is the blue line, and the efficiency, which is the pink line. Now, we function at maximum efficiency, which is over there, when the elastance of the ventricle is twice the elastance of the artery. Now, as you increase, and we function at suboptimal stroke work. So as I increase the afterload, the stroke work will increase to a point where it can't cope anymore, and that will be when the elastance of the ventricle and the arterial elastance are equal. Then the ventricle will fail and the stroke work will fail. That is the engineering definition of ventricular failing. So I will simply calculate the right ventricular stroke work. Obviously, the CVP will be elevated, but one is often uncertain. What does it say? Is it the ventilator? Is it fluid? Is it the right ventricle? I'll calculate the stroke work, and then if I have a stroke work which is not meeting the elevated pulmonary artery pressure, I know I'm on this side of the curve, i.e. technically I do have the right ventricular failure and I will act accordingly. You may ask me, well, look, how common is this? Is it really worth worrying about? It's extremely common. In 1994, myself and Justin Swanefelder looked at a group of patients who was in difficulty, saturation less than 90% on high oxygen, PAP pressure average above 25. We had 60 patients, and then we checked on their right ventricles, and we found that in 30 of those 60, half of the patients, we had right ventricular failure in as much as the right ventricular stroke work index was less than 8 in the presence of an elevated pulmonary artery pressure. CVP was elevated, poor cardiac output, and there's the shunt that we were dealing with. Those where the right ventricle remained competent, they had in fact had a PAP pressure which was higher. The CVP was less because the ventricle was coping better. The cardiac output was better, and we even had a higher shunt fraction in those patients. But point being, in 50% of this group of patients, 60, we could show that a failing right ventricle in ARDS was part and parcel of the difficulty in oxygenating the patients. Now you can imagine, if you don't consider this in your management and you simply increase your PEEP, you're not going to get a response. In fact, you may well embarrass the circulation even more. And you don't understand why I'm not getting a response to PEEP. The reason is you're addressing the wrong problem. The problem lies at a circulatory level and not necessarily at a lung level. And unless you've got an open mind about these, you will miss this. I found it sort of interesting that now editorials 2009, right ventricular function, 2014 discussion, 2014, it's now again becoming fashionable, the right ventricle. But let me remind you that we have shown this in 1994 already to be a major issue in the patient with ARDS. And it's about time that it's been highlighted. Now, just to show you what happens in the patient who is less fluid overload, and I'm sort of taking a bit of license here. This is a patient with a phlebotomy. There's the PAP pressure, there's the shunt. You can see that in the phlebotomized patient, either the one that will be animals have a lower intravascular volume, the shunt fraction will be less, and your PaO2 would be higher, and they still have a good blood pressure. The fluid loading in the patient with ARDS is not only bad for the lung water, it's severely detrimental to the right ventricle. And I think this slide shows it very well. This is the normal PAP pressure. There's control, there's volume loading. And as you would expect, as I give volume, the right ventricular end-outside pressure increases a bit. So I'm starting the heart and the stroke volume increases nicely. And this is what one would expect. If you have pulmonary artery hypertension, and this is the values that was used in this study, look what happens if you volume load. The CVP increases more, but note what happens to the stroke volume. It decreases. Now, if you know how to calculate stroke work, you'll know that this will, in the calculation of stroke work, it will equate to a reduction in the right ventricular stroke work. So the right ventricle fail. So the point being, fluid loading in the presence of ARDS, and more so if the right ventricle is compromised, is contraindicated. And it's a common thing. People tend to give fluid once there's a bit of instability with the pressure, but one's have to make a concentrated effort to try and avoid doing so, because you will fail the right ventricle if it's already in difficulty. And here, Pinsky and Mayer, they again discuss this issue, and they make the point that fluid loading is contraindicated. I can skip this. Vasodilators does not help in pulmonary arterial hypertension. In ARDS, what it does, it decreases your PaO2 because it further reduces the hypoxic pulmonary vasoconstriction or whatever is left of that, and you end up with a reduction in your in your PaO2. Now, this is I think, a very, very instructive slide of Lahakis in 1981. And this is another problem that we have to deal with. What they've done is they've caused pulmonary hypertension to the point that the right ventricle will fail. There's a right ventricular systolic pressure going up, then failing, and then there's a recovery. I'll come to this. You can see the right ventricular end diastolic pressure increases, as one would expect, as it goes into failure. And at that point where it fails, the mean arterial pressure is now decreased. So there's now systemic hypotension occurring because the right ventricle is failure. Now, what I wanted to look at, if you look at your hyperemic response of the right coronary artery, you can see there's no hyperemic response, i.e. the right coronary artery is maximally dilated at this point. So the right ventricle is under severe strain, and you can see that the lactate pyruvate ratio clearly indicates that there is right ventricular ischemia, and the cardiac output is decreased. So what they then did is they used phenylephrine to restore the systemic pressure. That's all they did. And look what happens to the right ventricular, the pulmonary artery pressure increased because the cardiac output now increased again. The right ventricle functioned at a lower end diastolic pressure, and the hyperemic response came back, so the lactate pyruvate ratio returned to normal. So the right ventricular ischemia was relieved. Point being that in the presence of a right ventricle under strain, systemic hypotension is devastating, because what you're now doing, you're adding an ischemic right ventricular insult, and you have to maintain the perfusion pressure. Remember, the right coronary comes out of the aorta, so you have to maintain the systemic pressure to be able to prevent an ischemic failure of a right ventricle, which is already pressure loaded and cannot cope because it's a thin wall structure. So I think this is an important lesson to keep in mind when you deal with these patients. So the right ventricular, to preserve the right ventricular function, well, remember it's pressure overloaded, it may well be ischemic, and remember there's an inflammatory depression of the right ventricle. I'll show the slide later on. So one's got to deal with this. I do not use propofol as a drug to sedate these patients, because we have shown that propofol causes severe myocardial depression. There's a hysteresis. As the blood level goes down, the ventricular function does not recover. You should not use excessive fluid loading. You must maintain the systemic pressure, and I, for one, would like to caution against vasopressin. I'm afraid that in a low flow scenario, using vasopressin ends up with liver necrosis every time. So I resorted to using methylene blue to restore the pressure, and I must say it works quite well, and it buys you time. And then I support the right ventricle. I start early with an inotrope, and my choice will depend on the systemic pressure. If I have a normal systemic pressure, I'll use Domitrix in smaller doses between 5 and 10 mics per kilo per minute. If the systemic pressure is somewhat unstable, I'll use adrenaline starting at 0.05 mics per kilo per minute. And then don't forget levosimendan, because every failing heart has calcium dysregulation. It's one of the hallmarks of a failing myocyte. And levosimendan is the one which can partially overcome this. And my experience with levosimendan in cardiac patients is very, very positive. It gives you 1 to 2 liters of extra cardiac output after a single dose lasting for 3 days. Obviously, you first got to fight with a medical aid, but nevertheless, so keep that in mind. Why don't we use nitric oxide? Because it's been shown by Forstel from the Zapol group that it causes a very pronounced reduction in PAP pressure in a sheep model where they had a pulmonary artery hypertension caused by alveolar hypoxia. So this was the archetype of the spasm of the pulmonary artery, which we know is driven to a large extent by the alveolar PaO2, or reduction in the big AO2. So why wouldn't it work? So we tried this in patients, and this is, it was 8 patients. We had different levels of nitric oxide, inhaled nitric oxide, and you can see that the results were very disappointing. And I'm not going to show you, but the data also showed that the right ventricle did not benefit from whatever slight reduction there may have been. So it did not resolve the problem. But looking back at it, we were wrong to think it will work. The reason was this is not a disease of pulmonary artery spasm. It's mechanical obstruction probably. And of course, the nitric oxide will not relieve that. Now, just a couple of final slides. We're in the middle of this COVID madness. So, and the two things which I found interesting. The one is there were suggestions at one point that the lung injury is different from ARDS, and the other one is that the whole thing can be explained by clotting and DIC, and I think I've dealt with it. So I went and I had a look at some of the data which I could find just to make a comparison. Now, look at the histology. This is a COVID lung, and this is from my experiment, from one of my patients, and clearly there's no difference. And by the way, you can see the necrosis there, which is no different from the subpleural infarctions that Zapol has shown. This is my ARDS, hemorrhagic edema, COVID, hemorrhagic edema early on. Same here with COVID, again, edema in the lung. And here you have the loss of alveolar lining and inflammation occurring. And then you have the protein rich exudate collecting inside the lung, as I have here. And this is in COVID interesting. They have these blobs of this protein rich stuff lying inside the alveolus. And there's some suggestion that hyaluron is decreased in these patients, so it may be a reason why they collect this. But you can now see if you have this and you use a thrombolysis nebulization, you may well be able to resolve this these blobs of collection inside the alveoli. So this is there's the studies where this came from. This is then the inflammatory phase in my patients, and this is in the COVID patient. And there's the hyaline membranes, and there's my patient's hyaline membranes. And again, there's the clot in the medium-sized arteriole in my patient. There's the pathology in their patients. There's another one in a COVID patient. And this is what Zapol has shown us a long time ago. Then you have fibrosis, the blue being the fibrotic tissue, and again they also show the fibrotic tissue in their lungs. So I think that what we're dealing with is ARDS, but the cause in this instance would then be a viral infection causing inflammatory storm and systemic inflammation, and then we understand what happens to the lung. So the general principles will apply to a large extent in the COVID patient. Then the question of clotting. Now, just to make a point, one must just be careful how you define DIC. It's a thrombohemorrhagic disease, and you can grade this. This is one of the gradings that's being used. This is the International Society, and this is the Japanese one, acute medicine, and this is the another scoring, acute medicine scoring system that they use. And so they can actually grade this and the degree of DIC. So you've got to understand that initially you'll have an accelerated clotting and markers of such. And then eventually when there's consumption of the factors, you'll end up with bleeding, and the markers will show that you've used up all the clotting factors. If you look at the data that came out on some of these patients, here you can see, look at the prothrombin time. There you can see in the non-survivors, it was increased. The D-dimers was elevated. So they had, in fact, a slower clotting, and they had active lysis, clot lysis occurring in the patients, as you can see also from the FTPs. If you look at this slide, this is in the Lancet, showing you an interesting thing is look at the platelets. The platelets remained elevated. So this is interesting, I think, that they don't consume the platelets as I'm used to seeing in my patients with a proper DIC by the time I get hold of it. So this is interesting that they maintained their platelet count. Prothrombin time, again, it wasn't aggressively increased. And the D-dimers, again, was increased in their patients. Now, the thing is, I don't know from this study whether these patients were on some form of heparin prophylaxis. So I'm not exactly sure what the data tells us. This is also from Wang in 2020. This is COVID patients. Again, look at the platelet count. Again, the platelet count remains okay. And this is where I think that one should perhaps think about discipline, trying to contain the role of the activated platelet in these ill patients. Prothrombin times, there you are, it's not very high. It didn't change much, in fact. And the APTT, of course, didn't change. The D-dimers were elevated significantly in the patients who went to the ICU, who were more ill. So clot lysis is a big part of the process. This is data which was only which was published by Fogarty. There's where I get this from. This is where I obtained this from. Again, showing you the D-dimers, which is severely elevated by day 4 as compared to day 1. So they come in with an activated clotting, and it remains very much activated. Look at their platelets from admission to day 4. It remained elevated. So for some reason, they don't consume the platelets as much as I would think that a severe DIC would do. And then your prothrombin time, your activated factor, tissue factor, of course, that is prolonged. This is an interesting study which was sent to me last night by the journal. It hasn't been published, it's only been peer reviewed, and it's due to be published, Journal of Thrombosis and Hemostasis. Tissue plasminogen activated treatment in COVID patients, and they had 3 cases, and they used a small dose, 25 milligrams of I think it was ectalase, I can't remember now. And what they found is that the PF ratio, the PA to FI2 ratio, improved on average from 103 to 2 for 1. Only 3 cases. The one died in any event from it went. Things went from bad to worse, but at least the oxygenation problem could be addressed, even if it's just temporary, by using this. Now, remember what I showed you with the nebulization approach and that study. So I think that this is, in this whole COVID thing and our understanding of ARDS, this may be a somewhat different approach, or new, it's not new, but a different approach, which hasn't received much attention in the past, and perhaps it should be pursued more aggressively in the future. This is just to confirm again, the Journal of American College of Cardiology, they looked at right ventricular longitudinal strain in the patients with COVID, and just to show you that there's an increase in right ventricular size. There you can see that the longitudinal strain clearly showed dysfunction, and the TAPSE was, although the value per se is not too bad, it is less than the other patients. So just to make the point, right ventricular involvement in the COVID patient is, as one would expect from our understanding of ARDS, it's a given. So unless one is alerted to this and look out for this, it will be missed, and it will have pronounced effect on outcome and oxygenation of the patients. Here they show that if you look at the mortality of their patients, that the longitudinal strain is the best predictor in terms of of mortality in this patient. So clearly, it's an important issue. It's not something to be ignored, and one need to be aware of it and to be on the lookout for this. Just a final slide. Keep in mind that all of this is happening on top of the effect of inflammation or sepsis on myocardial contractility. Here's the ejection fraction, is the left ventricle. And there was Nathanson in 1988 already. Look at this severe decrease in the ejection fractions that occurred in your patients once they've induced sepsis. It was at their worst by 2 days, and by 10 days they have recovered. So you get a temporary significant reduction or temporary reduction in your myocardial ejection and function, and if it will recover, of course, provided you can get the patient to survive, speak for itself. But this is an additional problem that we need to figure in when we try and salvage a right ventricle, which is suddenly being opposed by an elevated pulmonary artery elasticity or afterload, and may have been volume overloaded, or there may be systemic hypertension with ischemia, and then without doubt you will get into severe difficulty. Thank you.